Is it okay to say some names if I have any? Or
Well, we cut them out if they just like.
I mean,
We'll bleep the names. If you say Voldemort, we'll bleep it. We'll bleep it. Don't worry.
Yes.
You must not be named.
Hey, man.
All right, welcome back to the OuchCast. Today we're going to focus on something interesting. It's going to be regenerative medicine. And
Never heard of that before. It's great.
It's going to be an interesting topic because I think both of us know not a lot about this. So I feel like we're going to learn a lot today about this. Who have you got for us?
You know, today we're really excited to have great friends of mine, ours. But we have David Woznica, visiting us from, I think he works here in Chicago, got an awesome practice in Florida, affectionately known as the Wizard of Woz. I've done a lot of expertise in this field. And then we have Dr. Erik Shaw, Atlanta. I like Atlanta, ATL. A lot of work in spasticity and regenerative medicine here. I think you're going to have some good questions and really learn about this field. Something that's really emerging, but needs some sort of like discussive elements to figure out how to appropriately apply this to our patients.
Yeah, thanks for joining us, guys.
Yeah, happy
My
to be
pleasure.
here.
Yeah, absolutely.
Let's start off with something simple. Just kind of at the very basics. What defines regenerative medicine? What exactly is it?
I would say any injection that you're putting in the body trying to make a tissue grow.
Okay.
I think that's pretty good. When there's a tissue defect and you're introducing a substance to force the body to help to heal that tissue.
Gotcha. So you're kind of capitalizing on the body's ability to do something that maybe it's not doing initially. So you're pointing at something and saying, heal this, because it's not being healed. So you're kind of forcing its own regenerative process.
It's typically a part of the body that doesn't have its own good intrinsic blood flow.
Okay.
Like a tendon, ligament, or a joint.
I mean, this is so different than what we normally inject. We're injecting steroids. Right?
Yeah,
the exact opposite.
I tell my patients I'm literally doing the opposite of steroids. You're going to walk out feeling more sore, but then over the next few months, you're getting stronger and better tissue.
Right.
And what kind of things are you injecting then instead of the steroids?
Instead of steroids, it could be dextrose prolotherapy, which is a high concentration of sugar. So it causes osmosis to really stress out the cells, cause inflammation. Then I use PRP a lot as well.
And PRP stands for what?
Platelet-rich plasma.
Okay, so that's the same thing that Kobe Bryant used.
Yeah, exactly. But he went all the way to Germany or something, right?
I
Can't
can't
come
remember.
to the Wizard of Woz.
He could have come to Florida or
Wizard of
Chicago,
Woz.
I mean, great steaks
Little
here,
do you know,
great
it's very
fish
close
there.
by.
I don't know why. But yeah, so platelet-rich plasma, blood draw, you concentrate the platelets, re-inject them. I'm sure, Erik, you do those as well.
Yeah.
And you can always use bone marrow aspirates, which are a source of lots of platelets and also mesenchymal signaling cells, also known as stem cells in some cases, where you're trying to use these tissues. You take these cells, you concentrate them potentially, and you put them in the area of the defect, trying to get as much growth as possible.
Yeah.
And then everyone's favorite, is fat.
Yeah.
Fat.
Just-
So the adipose.
Yeah, the adipose.
We try to get rid of that, but this is like you're putting it back in. That's crazy.
Yeah. You just say, shake it up and just throw it back in.
I got a question for you, Erik.
Yeah.
We have all this stuff. I don't even know how to choose which
Right.
one's which and when to use
Right.
it. And maybe some simple, basic ideas of when to choose what, and then we kind of bounce off those ideas from here.
So I think prolotherapy generally is if a tissue is a little bit stretched, but there's not a generally like a large tear or defect in it. Prolotherapy can be helpful for that. If you're trying to recondition the length tension of the ligament or the tendon, that can be helpful. PRP is when you want some healing, when there's a defect in like a meniscus or the joint itself or the labrum, or obviously the ligaments and tendons too. That it helps through the vascular endothelial growth factors, insulin-like growth factors, epidermal growth factors. It helps to basically draw the healing cells to that part of the body. Then like Woz was saying, over the next couple months, allow that tissue to heal. So actually you can have a tendon defect with a tear in it, which previously you would have to have surgery to go and cut it, take out the defect, sew that tendon back together. Now you can just inject, usually with ultrasound guidance. You'd have to have some sort of imaging, because doing it blind, you don't know where the defect is.
Yeah.
And you can inject it right there, and then over the next couple months with therapy and natural healing, it gets better.
Okay, so that was PRP and Prolo. What about when it comes to like the bone marrow aspirates and like the fat adipose cells? What do you use that for? Is that the same thing as PRP?
I would use it for the same situations as PRP. I got some restrictions there. Fat, for example, aspirates, I won't use near the spine. Right.
Oh, interesting. Why is that?
Because I don't want to get anything potentially
You don't want
into
it
a
to
blood
get
vessel.
fattier?
Okay.
Like, you
No,
don't-
yeah, exactly. You don't want to get a big fat spine, but you don't want to have any potential leakage into a blood vessel that could cause some kind of occlusion. So kind of like the way you would want to be worried about a particular.
Oh, interesting. So like an
Okay.
embolus.
Embolization.
So
Yeah.
exactly an
Yeah.
embolization situation. So even though you micronize this fat, there's still a potential risk. So I mainly use that for tendons and for labrums and joints.
Right.
Okay. Whereas bone marrow aspirate, I can use all over. I feel pretty safe with that. It's been filtered. It's cells.
But how does a novice like me, I see a tendon that's injured, torn on ultrasound. I have PRP. I have exosomes. I have all these other things. Where does someone start?
I would say, and if I just
Can we define that before we jump in? What is an exosome?
exosome is the protein derivative from these healing factors that are purified into a vial.
Okay.
And so it's not derived from the human, from the patient you're treating. It's taken off the shelf and then mixed with one of these
Yeah,
products.
so it's a communication molecule of a stem cell. So when you
Oh,
use, if I
interesting.
take bone marrow aspirate and I make it into a concentrated thing, right? And I inject your stem cells into a tissue, 99.9% of them aren't stem cells that can turn into anything, right? There's a small percentage that can. The rest of them release exosomes, but their exosomes go into the tissue that's around them, gets absorbed, and changes the way the tissue works. So if you're having a tissue that's kind of like dying, right? These stem cells release these kind of pro-growth molecules that get absorbed into the cell. It's kind of like the COVID vaccine. All right, you get this mRNA vaccine.
Yeah.
It goes in, expresses a new protein. But instead of being a thing that we made in a lab, it's something the body's stem cells are trying to make for growth. So the benefit of exosomes is, if you're going to be using them like variously, they are great. You can get the profile characterized, et cetera, per batch. Okay, so you know what's in each batch, and they can be like much like more sterile as opposed to like expanded stem cells, for example. But the downside is there's little homing. You have to put them where you need them. Okay, whereas a stem cell can home, so it will see the inflammation home to that area.
Oh,
okay?
interesting.
But an exosome is like the microscopes you need to see an exosome are very rare. Okay, there's like probably a handful in the world. I mean, and
I
like,
can't even spell it.
These are
like they're that small. These are really, really small extracellular vesicles. And in the way I think about it is like if you've ever heard of the rat studies where they put the old rat next to the young rat and they hook up their blood supplies, the old rat gets younger, young rat gets older. Okay, and I think a lot of that is happening because the exosomes, the young,
It's a very good tip for the audience.
yeah, yes, exactly.
Steal the youth.
They had those San Fran
Yeah.
company that was trying to like sell blood of the young kids, right? For a while, I think they were. I've heard,
Took a weird turn.
Yeah.
Vampires next episode. Vampires.
So essentially, these exosomes are going into the older tissue and fighting it off but the young rat is also getting older because the older exosomes are going into them. So it's an interesting like balance that your body has. So, exosomes IV, I don't know how potent they would be unless you're using a lot of them. And in my mind, if I were going to do that, I would probably start donating plasma. So I'm getting rid of my own exosomes, okay, because they're in the plasma, and then give a high dose IV. But this is all theoretical, of course. This is just stuff.
So with these particularly, prolotherapy is not something that's endogenously created in a human being, or you're not using it from the same person you're doing it on. And exosomes are not from the same person as well.
Right.
But for the other ones, when you're talking about PRP, you're talking about bone marrow aspirates or fat adipose. Does it matter on like the age of the patient? Does a younger patient do well because their cell content may be a little different than an older patient?
Yeah. So we do know that platelets decline as we age, and especially with comorbidities like diabetes and certainly cancers and things like that, they become a little bit less effective at healing.
Yeah.
And obviously, if they're anemic or have thrombocytopenia, they're just not going to have enough platelets to concentrate to be able to have enough juice, as it were, to help to heal the tissue. So you do have to be aware of the patient's general overall health. And I would say the difference between PRP and mesenchymal stem cells would be the degree of damage. If it's a really significant tear with maybe some osteophytes and really significant degeneration, you maybe want a little bit more power from the mesenchymal stem cells, versus if it's a little tear of a labrum or a meniscus and a little degeneration that's painful,
Yeah.
you could probably get away with just PRP.
Gotcha.
Okay.
No, go ahead.
For most of us, we see probably a couple of pain syndromes that are very common that might benefit from regenerative medicine, but a lot of us might inject, let's say, osteoarthritis of the knee. I tend to maybe do viscosupplementation or steroids. How would someone go about deciding this is a good candidate for regenerative medicine instead of some of the
I would say the data for knee PRP is far superior to viscosupplementation and certainly more than steroids. Steroids is very outdated. Steroids is if it's pretty far gone and they're pending replacement, just to give them some comfort so they can do some prehab to get stronger before their replacement. But PRP is by far and away has better evidence than viscosupplementation. And it lasts about a year. It doesn't last forever. You're decreasing the inflammation in the joint, helping to invigorate the cartilage a little bit. But these joint surfaces are constantly taking wear and tear, and so they're gonna start to break down again. So you might get a couple years out of PRP for a knee, and you'll have to repeat it, but it can be pretty helpful. The prolotherapy, like we were talking before, if you have like a sacroiliac joint that's a little bit loose or been stretched out after pregnancy or after trauma, you could maybe put some prolotherapy around the ligaments and into the joint to help tighten the capsule back up.
So is prolotherapy almost like a sclerosing agent? Like
Right.
it will
That's
essentially irritate it, and almost in some ways you're like forcing like a scarring down of that area.
Yeah, if you think about how you heal, all the med school textbooks, you have inflammatory healing, then proliferative healing, then remodeling healing. They all overlap, right? So all of these damages that we have chronically are things that our body gave up on trying to treat. So prolotherapy initiates the process, right? PRP initiates the process. Stem cells initiate the process. So you're going through all of these remodeling phases. And typically, I'm not a one and done kind of guy. I'm usually treating multiple times. And I think our approaches are slightly different because as a prolotherapist, I treat comprehensively. A knee for me is I care very little about the articular cartilage, because there's no pain sensors in the articular cartilage. So I can be in a knee and tapping the person's knee cartilage with my needle. They won't feel it. Like they might feel a thunk, but there's no pain, right?
Yeah.
A lot of the pain is coming from the ligament and instability. If you watch a UFC fight and they're doing the arm bar, right? They tap out because the ligament is starting to tear.
Right.
And so like prolotherapy is a ligament stability pain, and ligaments and other tissues as pain generators. So for me, I would treat a knee with about 40 different sites. Okay, so I'm treating along the MCL, I'm treating the ACL, I'm treating the LCL, I'm treating the medial patellofemoral ligament, I'm treating the tendons, everything that holds the knee wobbly, because it should be a hinge with a little wobble, right?
Yeah.
But we sit like this, we do all these things, and these tissues slowly stretch out through creep, right? And as a result, this creep gives us abnormal motion, and we're doing our 10,000 steps a day with abnormal motion, right? So I want to tighten these things out. And a lot of my patient population ends up being on the hypermobile spectrum. I get a lot of Ehlers-Danlos, sub-Ehlers-Danlos, just hypermobilities.
Oh,
and,
interesting.
And that's what's great for prolotherapy, because you're getting these white tissue ligaments that are just overly stretched out, right? And you're not stable anymore. Okay, and if it's in the high neck, you can get these weird things like Maldebark-Mont syndrome, vertigos.
I've never even heard of that.
Like,
how do you convince patients? Okay, so patient comes to see us. We think in steroids, but let's say we brought PRP and these kind of basic ideas from regenerative medicine. How do you convince a person who wants pain relief right now that I'm going to go through prolotherapy, which sounds like it would take some time, might even hurt a little bit in the beginning? Like what's your kind of talk track to talk to patients about it, to say it won't be an immediate fix, but long term it's gonna be a lot better?
Well, I just stress the dangers of steroids, that they're degenerative for the connective tissue. They cause all sorts of damage to the joint surface. Actually, they're destructive for cartilage. They're destructive for the capsule. They're actually worse for you. And especially in younger, healthier people that sustain maybe a significant kind of singular trauma or wear and tear trauma, where there's some laxity to the joint, I think it's pretty easy to say, like, listen, this is going to hurt a little bit at the beginning, but in a couple of weeks, you're going to feel better. And through a couple treatments, we're going to actually reinstill the health of the joint, whatever it may be, and so you're going to be able to continue your therapy. We haven't damaged any of your tissue.
That's interesting. Before we delve into that, there's actually something interesting you said about kind of the injections and the repeated nature of it. Just to recap, so 4 things: we got our prolotherapy, we got our PRP, we got stem cells, and then fat adipose cells. Obviously, there's subclassifications of these, and there's probably different preparations and formulations. Our etiologies are things. There's anything that causes ligament laxity, tendon laxities, arthritic processes, or instabilities. Obviously, if it's not like a surgical instability, but like kind of more of a laxity where it's a kind of maybe a dynamic instability. Those are things that we're looking at. And I know we didn't touch on this. Nerves, is that something you can use it for?
I do.
Like prolotherapy, PRP, what are we talking?
Well, it depends on what. Like, for example, if you're doing prolotherapy, you're going to use your high concentration around a nerve. You're going to be using a 5% concentration around a nerve.
Oh, like a 5% dextrose.
5% dextrose, right?
Yeah.
Because anything else than that is going to be inflammatory, and you don't want that. So, I mean, I think Mayo Clinic Proceedings had a couple of papers where they did carpal tunnel release, 10 cc's of 5% dextrose, improved their electrophysiologic, their nerves were working better 6 months later, as opposed to the steroid group, which, they felt better for a while, but then it kind of like didn't really improve anything. So it's really like, it's like for the nerves, it's most like you're trying to release them from the adhesions.
Right.
Okay.
It's a hydrodissection kind of phenomenon.
Exactly.
Can you put them together?
Can I put what together?
Prolotherapy and steroids? Do they feel better in the beginning?
Isn't that the opposite?
It's like some people might do
around
that.
a nerve, maybe you could, and around like in the carpal tunnel, maybe you could do such a thing.
Yeah.
But they generally respond pretty quickly to the 5% dextrose. So why do the steroid too?
Well, Dave, I have a question. So 10 cc's in the carpal tunnel seems like a huge volume.
Well, generally, I'm doing about a few cc's down low. Okay, then I see where it tracked, a few cc's down high, and I check the patients. Are their forearms tight? Some people are just tight fascial restrictors, right?
Yeah.
So if you think about what's called double crush syndrome, where you get a little bit of carpal tunnel at the wrist and a little bit of going on C5, C6 here, and now you have a lot of carpal tunnel syndrome stuff, right? But if you can release one of those restrictions, okay, the symptoms will get better. So this can also happen in the forearm. So I can track the release there, but if they seem tight there, okay, when I can activate them and cause some paresthesias or numbness tingling by pushing here, I will track under ultrasound and release deeper levels.
Of the fascia, not necessarily the nerve.
I'll release the nerve from the the fascia. I'll drop under and release. Yeah.
What about we talked about like the patients when they get them. What can they expect? Like, do they get better immediately? Is it like a day after they get better, or is there a greater amount of pain? Because you said it was an inflammatory response that you're creating. You're trying to force the cascade. Right. Is it painful initially? Do they have to avoid anything? And how quickly do they get better? And when do they see a response?
I would say in order of pain, least to greatest is probably the mesenchymal stem cells, actually, prolo, and then PRP.
Okay.
PRP can be really painful after the anesthetic wears off. For usually first couple days are pretty bad.
So PRP is the worst one.
Probably. I mean,
it burns on the way in too.
Yeah, but so there's some data that you can actually, but you can actually use a little bit of ropivacaine diluted, like 0.25%. And if you space that out, do a nerve block, maybe if it's shoulder, and then in the joint, and in the capsule, and in the supraspinatus, you can actually avoid a lot of the injection pain. Shoulders, for some reason, are exquisitely painful with PRP. I've had patients, several of them, actually pass out from the. I don't feel.
I haven't had that happen to me yet.
And they're down. But if you use anesthetic and you get it, you're covering all the spots. Generally, it's a little sore and achy, and they're fine.
But it sounds like this is very important to tell a patient that the initial injection of your PRP in whatever location, you need to be prepared for some form of discomfort that might be
without
sorry to cut you off.
Without anesthetic, PRP about 45 seconds to a minute and a half after the injection feels like something's exploding.
And it increases for about 10 minutes.
And it's pretty exquisite. And it's like 10 out of 10, 9 out of 10. And then it begins to wane, and then it becomes like a 6, 7.
I've done it a couple of patients, and they haven't felt the pain. Did I do something wrong?
Probably.
Did you put it in the joint? If you just put it in PRP inside of a joint, will be mildly noxious.
I see. Okay.
PRP outside of a joint. Okay, a tendon.
So I didn't miss.
You didn't miss. Okay, you put it inside of the joint. Remember, cartilage, no nerve endings.
Sure.
They'll feel a little noxicity because it's going to spread to the ACL and the inner menisci parts, and they'll feel something. It'll be like achy and blah blah blah, but it won't be.
But in your logic, it's better to have treated the MCL, LCL.
Yeah, I'm gonna be treating the whole
You're
darn
not
thing.
treating.
And you do that with Prolo or PRP?
I'll do it whether I need. Generally, I follow a prolotherapy approach for most patients because by the time they get to me, unless they're like young and healthy and they had like one little injury, the knee is like I'm just going to use the knee as an example. The knee is unstable. Okay, so I want to treat and stabilize the knee to get the best results overall. So I stabilize the knee. I might be using Prolo at first, okay, just to like save some cost, gets the stability, and assess how the patient will respond, and then might aggressively go to the PRP later on once they're more stable.
Right.
Because, the PRP is like Prolo on steroids, but the good steroids, the jacked ones, right? As opposed
The
to
anabolic, not the catabolic.
Yeah, anabolic, not the catabolic.
Not that we
The
condone
layman's
that.
term and the medical term.
Not the jack.
The Arnold Schwarzenegger types.
And I think that's true. And for Prolo, as what Dave was saying, typically we need to repeat it about every 6 to 8 weeks.
I do a 4 to 6.
4 to
usually.
6, yeah.
Four to
It depends on the
8.
protocol, but usually 3 to 5. Is that what you do?
Yeah, it depends on chronicity, but generally I would say between 3 and 6 visits.
Right.
For upper cervical instability, where they're getting the mal de Barkmont, where they're getting migraines, where they're getting.
Can you explain mal de Barkmont?
That's like it's the French term of like I'm got off a boat and I still feel like I'm moving on a boat. Right. So these are patients
wobble.
these are patients that they were all fine. Okay. And then they took a plane trip or something like that. Then after this plane trip, they just kind of feel dizzy all the time or kind of wobbly all the time.
And that's
okay?
C1-2 problem.
Well, that was the whole cervical spine.
Uh-huh.
And actually, before I learned prolotherapy and regenerative medicines, I hated patients when I was at the Yale Spine Center. I hated seeing a patient with a long neck. Okay, with neck pain and neck issues. The long neck, it always seemed to be a hypermobile female, okay, which are now one of my main populations, right? They had a long neck, so they had all these trigger points going on. And before I understood how this process worked, I was limited to like corticosteroids and PT, right? Or refer to surgery. And the surgeons didn't want to touch them because it didn't really look like a surgical case. Mm-hmm. So, but now these long necks, because they're on the hypermobile spectrum, they get this instability going on. And then they go on this trip. You're in this uncomfortable chair. Your head's wobbling like this.
We got to get you to Africa. You take some giraffes.
Yes, with the extended neck collars. Yeah, right. Well, they got the collar on, right? Yeah. Isn't that a collar? So yeah, they're neck collared. And now I can help them because I can restabilize the spine. So that's the main thing. And there's so much crossover of nerves. It's like almost like an RSD kind of thing to some degree.
Yeah.
Because you activate up here, it'll travel over here. Like C1 and TMJ pain, huge overlap. Okay, huge overlap.
But not to mention that, but like C5-6 through the nuchal ligament. There's so much.
I don't remember this in medical school at all. Like, I don't remember learning all this stuff.
Yeah,
Where are you guys learning this? Or what's some advice for people who are young and want to try to pursue this kind of therapy to get good training? Because clearly there's variations of what you can offer. Not without saying names or courses or anything, but is there like some advice you have in seeking out the appropriate mentors for this? Besides, obviously, you two.
Is it okay to say some names if I have any? Or
Well, we cut them out if it's like.
I mean,
We'll bleep the names.
If you don't
if
prove
it's
it-
a bad,
I mean-
if you say Voldemort, we'll bleep it. We'll bleep it. Don't worry.
Yes.
You must not be named.
Hey, man.
I was very blessed. I trained under Dr. Ross Hauser, okay, who, prolotherapy came from Drs. Hackett and Hemwall. And he trained directly under Dr. Hemwall in Oak Park, Illinois, and worked there with him and had an office there for 35 years. So when I first met Dr. Hauser, he was like, Dave, I'm going to show you how prolotherapy was done 50 years ago. And I really got to see how prolotherapy was done.
Was
50
this the
years
guy
ago.
that wrote that really long book?
Yeah, he wrote a book.
I
Like
think
Prolotherapy Anyway.
I've read through parts of that. Yeah,
We gotta
And
get that book.
And
it took 1,000 pages.
yeah, he likes.
I need the audio book.
Gotta get cliff notes.
And I mean, I owe so much to him because he's really been great. He's total genius on this kind of stuff, right? But he learned from the classics, like the surgeons that started doing prolotherapy a long time ago. And when I first saw it, I'm like, holy cow, this is aggressive stuff. But all these patients were like, as I was shadowing, like, this is the only thing that's helped me. I've had surgery, so nothing's helped me. Like, everyone else has turned me away. A lot of his patients and a lot of my patients have seen like 6 to 9 other doctors that have not helped them. Okay, so that's where I learned it from, and also the Hackett Hemwall Prolotherapy Foundation up in Madison, Wisconsin.
Yes, that's well known for that.
Yeah, they have a good little intensive course, and they do mission trips to the Central America where you can do like either sclerotherapy on people or do prolotherapy on people down there. like for a couple weeks at a time.
Yeah. So I trained in San Antonio for my for PM&R and for my pain fellowship. I studied with Dr. Somayaji Ramamurthy, who trained up here with Winnie back in the 60s, right? So there's a little bit of crossover because I definitely learned prolotherapy in fellowship, but we didn't really get all the details that you obviously have training with sort of the guru, as it were. But I do find it very helpful for patients if they can't afford the PRP itself. So
that's probably one of the problems is, at least in the United States, getting access to some of these novel regenerative medicine techniques may be financially difficult.
Yeah, because PRP, fat stem cells, and mesenchymal stem cells, insurance doesn't cover that. So, and some of these kits for the mesenchymal stem cell biopsy, just to get the bone marrow out of the hip, those are $1,000, $1,200 just for the kit.
Yeah,
and so, you can get pain from that actual aspiration, right?
Sure. I have a patient that has a pretty remarkable clinical neuralgia from a bone marrow aspiration going wrong.
So that's like an adverse reaction to some of these things.
I think he has MS, and they were doing it for monitoring or checking him for some other problem, and the surgeon just hit his clinical nerve, and he's pretty impaired from it.
Yeah, that's why
see that
that's why you use ultrasound guidance
well
to find that location.
Right.
Yeah.
So obviously we mentioned a lot about prolotherapy. I've heard this a lot. People will say like prolotherapy is one of those things that people don't want to admit as to how much, like how good it works, because sometimes we don't even know why it's working very well.
Correct.
But it seems to be one of those things that I've heard come up a lot through the years, through my training. People would say that like, I'm not really sure. But
but why does it work? It seems to work. Yes, yeah.
So, I mean, obviously we've covered a lot. It just kind of recapping the last part of it. Prolotherapy, obviously very useful for a lot of these laxities. The repeated injections. So with prolotherapy, this is obviously something that you're going to do on a protocol. It may be every 4 to 6 weeks that you're repeating this, and you're doing maybe 3 to 5 sessions of this for one particular kind of area of insult. And obviously the concentrations vary based on what you're doing. If it's nerves, if it's joints, it's tendons, ligament. The other thing that we worry about is, I mean, PRP, is that the same thing? PRP stem cells, are you repeating the injections? Are you doing?
As needed. So I will use, in my mind, prolotherapy is my technique.
Yeah.
Okay. The solution can be the dextrose. The solution can be the PRP. It can be the bone marrow. It's how I'm treating the patient, right?
Oh, interesting.
So for example, I do think they have severe arthritis and internally they are causing pain. I did like a little intra-articular block and they got better, right? But do I want them to spend $5,000 on a lipo treatment when I know when I know their knee's unstable? I want to get the knee stable so whatever repair I get when I do the lipo treatment later will last longer.
Right.
Okay.
Yeah.
So it's like, you can like fix it internally for a while, but you want it to be as fixed as possible for as long as possible.
And I want to add to what Dave's saying. You can repair the joint, you can do the treatment, but if you don't do the therapy afterwards to get because frequently these patients are really debilitated.
And you need physical therapy.
Physical therapy.
That's very important in all of this.
Because the muscular strength,
couples therapy after.
Watch it, Neal. We're gonna have some couples therapy later. So the eccentric
mental therapy.
the eccentric strength of the patient typically is the first thing that goes. They may still have some concentric power, but with this pain, they really use the joint less. They're not able to exercise like they were if they're a healthy person. If they're, let's say, wheelchair bound and have a lot of shoulder or an elbow pathology, they're not able to push the wheelchair as much. So they're just not. Those muscles are very deconditioned. They may have altered biomechanics. So you really have to couple it with a good therapy program.
So all this is in context. All of these therapies, regardless, are in context of functional improvement through a therapist, activity,
and then a home exercise program too.
Yeah, every patient's different. I mean, I've had like strong, healthy, athletic females with a lot of low back and sacroiliac pain, but otherwise they're strong and healthy, but they got a lot of issues. I've done one treatment, and surprisingly, they're good for years, kind of a thing.
Yeah.
And I know they could use more to get some more stability, but they're at that point where that tissue can now understand, they can hold the tension.
Whereas you give steroids every 3 months.
They have the muscle back.
They have the strength.
The opposite is giving steroids every 3 months, not accomplishing anything, but just hiding the problem, maybe making it worse.
Exactly.
Yeah, and they're tethered to those injections.
Exactly.
We've covered a lot.
I'm like,
I've learned a lot, by the way.
There's so much that we went through. I know that we could probably do this for hours and we could go into each of these things, but
I would just like as just a sum up, this is a different sort of mentality to treatment. You're not seeing these patients on a routine basis for an injection. You're doing it once or twice or 3 times with the intention of they don't need you for a long time.
Yeah,
right?
that's the hope for everybody. That's what we should be doing in medicine to begin with.
That's
Yes,
right.
yes.
And I agree with you, but that's not necessarily how the model is built.
not the preventative model
not the
or the regenerative model.
That's right. So I really think it's a much better philosophy. It's a much better targeted. You're helping the human being to restore their natural function so they can go back to their normal activity.
And that's what we really want to do as physicians. That's what
right.
we really
Right.
want.
Right.
Yeah. I like that. I think we did a lot with this.
This
So
has been great.
Yeah, I don't know if there's anything else that you guys have, but it's been awesome kind of sitting down. I'm sure that another point we can kind of delve further on each of these specific things. But
Yeah,
It's
there's
wonderful,
so many-
to,
there's so many
wonderful to have the
details
Wizard of
underneath.
Woz here. And we need one nickname for you now. We've got to come up with one.
Well, all right. We won't appropriate anything.
No, not right now.
So
all right, guys. Thanks for coming to sit down with us.
we really appreciate it.
pleasure.
I enjoyed it a
great.
lot.